We'll start with congenital heart diseases. The most common congenital heart disease in children is ventricular septal defect, as we very well know. Left to right shunts, we can divide the congenital heart disease into acyanotic heart disease and cyanotic heart disease. Acyanotic heart disease comprises of left to right shunts and stenotic lesions, but left to right shunts are the most common ones, that is VSD, ASD, and PTA. Amongst the cyanotic congenital heart disease, just remember the four most common five cyanotic heart diseases are tetralogy of Fallot's, tricuspid atresia, truncus arteriosus, transposition of great vessels, and TABVC. Now we'll begin with left to right shunts. The most common left to right shunts are VSD, which comprise of 27%, ASD 13%, and PDA 11%. The normal structure of the heart, the box diagram, right atrium, right ventricle, left atrium, left ventricle, the blood going through the pulmonary artery to the lungs and from the lungs to the left atrium, and blood from the left ventricle going to the aorta, and the connection between pulmonary artery and aorta is the PDA if it is present, patent. Now left to right shunt in case of atrial septal defect, the left to right shunt is between left atrium to right atrium, and there is a shunt, but there is no murmur because of this shunt. The first heart sound is loud because large volume of blood is going to the right ventricle, and against that large volume, when the valve closes, there is a loud first heart sound. The increased flow through the tricuspid valve will cause a delayed diastolic murmur. First heart sound, because of increased blood in the right ventricle, there will be right ventricular enlargement. Increased flow through the pulmonary artery will again cause ejection systolic murmur, and the second heart sound will be loud when it will close. The pulmonary vessels will have more of blood, and therefore there will be congestion of the lungs, leading to CCF and plethoric lungs on X-ray. Increased flow to the left atrium will cause left atrial enlargement. Over the period of years, increased flow through the pulmonary vessels will lead to pulmonary arterial hypertension, and this will lead to reversal of shunt. Wide splitting of the second heart sound is seen, especially in ASD and VSD. There will be wide splitting of the second heart sound. Now, atrial septal defects, they constitute 13% of all the congenital heart disease. There is an abnormal communication between the two atrias. ASDs are of three types: ostium secundum, ostium primum, and sinus venosus defects. Ostium secundum defect is 70% of them are ostium secundum defect. The defect is at the fossa ovalis, or rarely superior to or posterior to fossa. Ostium primum defect, 30% defect are seen as ostium primum. Defect is in the endocardial cushion lying inferior to the fossa. It may be associated with mitral valve defect. This is not a good one. Sinus venosus defect is 10% associated with defect at the entry of the superior vena cava and right atrium. Again, we'll just repeat the hemodynamics. Oxygenated blood from the left atrium goes to the right atrium. Right atrium receives extra blood, causing right atrial enlargement. Large volume of blood passes through the normal tricuspid valve, causing delayed diastolic murmur. Now, large volume of blood received by the right ventricle will lead to right ventricular enlargement, and which gives the cardiac impulse. The large volume through the pulmonary artery causes ejection systolic murmur and delayed closure of the pulmonary valve. Therefore, A2, P2, there is a wide splitting of the second heart sound, and there is a loud P2. As the age advances, pulmonary hypertension occurs. Clinical features: mild effort intolerance, chest infections are repeated, congestive cardiac failure sets in the later stage, parasternal impulse is there, A2, P2 are widely split and fixed, systolic thrill and murmur in the P2 area due to flow through the pulmonary wall. It is an ejection systolic murmur. The complications are rare. After the age of almost 20 years, pulmonary hypertension may set in. ECG may reveal right ventricular hypertrophy and right bundle branch block. X-rays will show mild cardiomegaly, right atrial and right ventricular enlargement, pulmonary artery is prominent, and there will be plethoric lung. Treatment: includes treatment of infections, congestive cardiac failure, that is digoxin, diuretics, AC inhibitors. These are the treatment of congestive cardiac failure. Surgery is the permanent answer. Common syndromes associated with ASD: Down syndrome, Holt-Oram syndrome, Gluten-Becker syndrome, and Noonan syndrome. Now coming to VSD, it is the most common amongst the congenital heart disease, constituting 27% of all CHDs. Location: 90% of VSD are membranous, in the membranous part of the septum. Others are in the muscular part and can be multiple. Syndromes associated with VSD are trisomy 13, 15, 17, 18, absent radius and ulna, polydactyly, and syndactyly. So ventricular septal defect hemodynamics, there is a left to right shunt between left ventricle and right ventricle. Left ventricle enters the right ventricle through the defect, leading to a murmur. At the same time, right ventricle is also contracting, so the blood is almost directly going to the pulmonary artery. Large volume through the but this shunt left ventricle to right ventricle shunt will lead to a pansystolic murmur. Large volume of blood through the pulmonary artery causes ejection systolic murmur, delayed, and therefore there will be delayed closure of the pulmonary valve, leading to delayed P2. Also, there is early emptying of the left ventricle causing early A2. There is a wide splitting of the A2 and P2. Increased blood in the left atrium causes left atrial enlargement, and mitral valve will also give a delayed diastolic murmur due to increased flow. The shunt itself gives a pansystolic murmur as blood is going through. The shunt is in systole, and this is best heard in the tricuspid area, that is the sternal border, third, fourth, and fifth intercostal space. Patients are symptomatic around 6 to 10 weeks. Congestive cardiac failure will develop. Palpitation, dyspnea on exertion may be seen. Frequent chest infections, wide pulse pressure, hyperkinetic precordium with systolic thrill, cardiomegaly with left ventricular apex. In small and moderate size VSD, right ventricular hypertrophy comes to normal after decrease of pulmonary resistance. In large VSD without PH, there will be left ventricular hypertrophy, and lungs will be plethoric. LVH depends on the size of the shunt. Aorta normal or maybe small in size. In left atrial hypertrophy is seen in large shunts. If VSD small heart size is normal, pulmonary vasculature is normal. If VSD is associated with PS, then the heart size may look to be normal. If there is pulmonary hypertension, heart size come back means there will be reversal of shunt once the pulmonary hypertension sets in. Treatment, medical treatment, we have to treat congestive cardiac failure, treat the infections, anemia, and C for endocarditis. Surgery is the ultimate answer. CCF indication: CCF in infancy not responding to medical treatment. Left to right shunt is large. VSD with PS, PH, or aortic regurgitation. Surgery is contraindicated if there is reversal of shunt. Surgery: closure of VSD with a Dacron patch through right atrial approach. Surgery is advised if PH develops within 2 years of development of PH. Complications of surgery are blocks and residual VSD. Now coming to patent ductus arteriosus. It is a common communication between the pulmonary artery and the aorta. Aortic attachment is just distal to the left subclavian artery. Ductus arteriosus is normally present in fetal life. It closes normally after birth. It constitutes 11% of all cardiac defects. Left to right shunt from the aorta to pulmonary artery. Flow is both during systole as well as diastole, as pressure is always higher in aorta than the pulmonary artery. This left to right shunt causes murmur, and the murmur is in the systole as well as diastole. Therefore, it is a continuous murmur. Left atrium receives large blood, leading to enlargement. Large amount of blood going through mitral valve will accentuate the first heart sound and also lead to delayed diastolic murmur. Left ventricle also receives more blood, leading to left ventricular enlargement, and A2 will close it because large amount of blood is going through the aorta. So there will be a paradoxical split or reversal of splitting of the second heart sound. Large volume coming to aorta causes aortic dilatation, giving clicks and ejection systolic murmurs. Patient becomes symptomatic early in life, develops CCF around 6 to 10 weeks of life, or even earlier within 7 days of life. In older children, there is effort intolerance, palpitation, and chest infections are repeated. As there is a leak of blood to PDA from systolic blood, there is a wide pulse pressure and collapsing pulse. Prominent carotid pulsations also are seen, and cardiac impulse and apex beat are hyperkinetic. Continuous systolic murmur plus thrill in the second intercostal space is seen. So if shunt is large, first heart sound is accentuated, second heart sound is normal or paradoxically split. P2 is louder than normal. Continuous murmur is best heard in the P2 pulmonary area. Investigations to be done are ECG, X-ray, echo, and we can see a cardiomegaly with left ventricular enlargement. In newborn and infants, pulmonary hypertension is present at birth, causing ejection, ejection systolic murmur. Later, as the pH decreases, the murmur becomes continuous. CCF is seen. In PDA, pulmonary hypertension later due to flow develops earlier than VSD. As pH develops later, diastolic component decreases. So the murmur becomes ejection systolic murmur. If left to right shunt becomes, once the pulmonary hypertension sets in, there will be a reversal of shunt and there will be differential cyanosis. Treatment of patent ductus arteriosus, arteriosus, we have to close the PDA by, for closure of PDA, we can give indomethacin, but nowadays we can prefer giving ibuprofen because indomethacin is toxic. Surgical ligation also can be done. And if we want to keep the patent ductus patent for some other reason, if it is a ductus dependent lesion, then we have to give prostaglandin infusion to keep the ductus open. So this is regarding PDA, VSD, and ASD. These are the three common shunt, left to right shunts, which are commonly seen in children, leading to congestive cardiac failure, repeated chest infection, and failure to thrive. So these are the common cyanotic heart diseases, and the most common cyanotic heart disease is tetralogy of Fallot's. The four components of tetralogy of Fallot's are VSD, pulmonary stenosis, overriding of aorta, and right ventricular hypertrophy. Patient go into repeated cyanotic spells, and we have to treat these patients as early as possible. We have to treat their cyanotic spells, and we have to do different surgical procedures to treat tetralogy of Fallot's. Thank you very much.